See, liver function test, basically we will have to assess the status of functions of liver of any individual. So, liver is the largest organ and it performs the main metabolic functions, and I will discuss the functions of liver also in between, because jaundice was the main thrust area, because for jaundice most of the patients usually come, and for edema. Edema means and swelling of the body. These are the two main reasons which I will discuss in detail. See, the liver is an organ today, you know, all the there are many hospitals which are organ specific. See, for eye, you are having an eye hospital. For liver, there is an institute, I am telling you, it's not that easy. In one class, it cannot be covered. So, the India Reference Institute for Liver Diseases only, ILBS, New Delhi. It is famous for functioning only for liver diseases. And there is another institute, Asian Institute of Gastrology in Hyderabad. And third institute at Kolkata, we are having also at Indian Institute of Liver and Digestive Diseases, Sonarpur. So, can you understand there is a full institute, just like immunology. So, it cannot be covered. And in all medical colleges which are teaching DM courses, they are in DM in gastroenterology, they are having another unit. And those who are dealing with the gastroenterology, they are having liver section. They will have somebody specializing in stomach, somebody specializing in gallbladder, somebody specializing in intestine, large intestine, like that. So, it is not that easy. So, why I told you, because you must know at this stage as a medical student, there are many institutes. Maybe you may be suffering, your family members may be suffering, or your parents may be suffering. So, where to refer that patient? The best center to refer any patient is to send it to ILBS. And then it is a very costly institute, it is a private institute, and of course, Kolkata is there. So, liver function test is basically assessment of functional state of a given individual. So, function means I am functioning, I am talking, I am walking. This is a function test, this is a real time test. But in liver function test, although this name is given, we do not do real time liver function test like glucose tolerance test. We have given or administered glucose to the patient, light off for the বেশি আমার চোখে প্রবলেম আছে সো বেশি দেখতে পাচ্ছ না ওখান থেকে লাস্ট বার দেখতে পাচ্ছ so if let me tell you, we have given glucose to any patient and then we are sequentially measuring glucose in that particular individual over 2 hours time. So that is the functional status real time. The patient has taken and we are measuring this thing. So in liver there were function tests, but they are of historical significance. They are not done nowadays. So what we do basically, so in reality, LFT, in real-time functional tests are not done, just like OGTT, or real-time function test is there. We have administered radioactive iodine. You know in thyroid gland, radioactive iodine is taken up by the thyroid gland. After we administer iodine, we want to see how much of iodine has been taken up by the thyroid. That's a real-time testing. But here we indirectly assess the ongoing status, functional status of the liver. So in true sense, we are not doing that real-time functional test. এই পয়সাটা এটা কাজ করছে না, একটু টাইম লাগবে, কাজ করছে না এটা রিনা রিনা আমার কাছে ওটা দাও তো হ্যাঁ. So why the liver test is done? You note down this one. So to confirm a clinical diagnosis of jaundice, you will come across jaundice cases in OPD, in medical OPDs or surgical OPDs definitely, and you know that this is a case of jaundice. Now the principal purpose of doing this test is to know what type of jaundice it is. This is hemolytic, obstructive or hepatic jaundice. Clinically you will be able to diagnose, but most of the situations you will not be able to assess what is the degree of damage. So we have to assess we have to do the liver function test and to assess the degree of damage. And once this is done, now patient has come, to till recovery, you have to monitor the patient. Till recovery means till normalization of the all the liver function test report. So for monitoring purposes, it will be required. So today you have done, a patient has come, you have ordered for liver function test, you know the status. Then at what interval you will do the test, that you have to decide, and that is dependent on the type of the case. That is called monitoring, and you have to monitor the patient till normalization of the report. And if the report is not normalized, that means the patient is having some problem. You can treat, you can refer to a senior person or to a higher center. One thing I am telling you, a liver is having a large, very large capacity to regenerate and to recover itself, because out of total liver, if only 1/6 liver is present, functions, then it will be able to carry out normal functions. So 4/5 of the liver is acting as a reserve. Now normally, whenever there is a disease, liver by itself recovers because of its tremendous regeneration capacity and because of the large reserve capacity. But by chance, if that 5/6 of the liver is damaged, and if only 1/6 liver is there, it is very difficult. The patient may be moving from here and there, but cure will be a real distant reality, honestly speaking. Because liver disease, chronic liver disease usually do not recover, and at times liver transplantation will be also required. Because for that 1/6 part has now been, it is within the disease, 5/6 has been damaged. So that part you must remember. Most of the time, everybody takes the credit. I have treated the patient, or he has gone to the patient, that institute. It is not like that. Because of the reserve capacity, because of the tremendous regeneration capacity of the liver by itself recovers. See, there are three things. One is pre-hepatic. Three types of jaundice. This is basically hemolytic. Before it reaches the liver, so most of the times a huge amount of pressure. That part you have understood. Now, as a routine, before any major operation, liver function tests are done, because many anesthetic agents are hepatotoxic, means they damage the liver. So if somebody is having already a damaged liver, the anesthetist has to decide what type of anesthesia will be given, and even after giving that anesthesia, they will monitor it. So that is a routine procedure, and the anesthetist must be very much careful about the status of the liver function. So before any major operation it is done. And in otherwise normal individuals, most of the diseases, common diseases are asymptomatic, like hypertension, like diabetes. Some of you or I may be having liver diseases, but I don't have any symptoms. Only on doing a liver function test, I may get an abnormal report. So in an otherwise healthy individual, medical checkups are done periodically to assess the various functions like eyesight, like hearing capacity, like your diabetes, hypertension. So by casual liver function test assessment, liver abnormality can also be done. And This can be done once in a year. After 40 years, it is done normally. So, in many asymptomatic cases, asymptomatic means they don't have any symptoms, and symptoms depend on many things. I will tell you one day that despite having diseases, advanced disease, even cancer, most of the patients remain asymptomatic until and unless the disease had reached an advanced stage, because of the large reserve capacity of the body. The reserve capacity of the body of a young person is quite different than that of an adult and that of a child also. So, that depends on the underlying reserve capacity of the body. Next. So, there are many liver tests, function tests we are taught when we are students, but only 6 tests are done. Useful, only write down the names and you will be able to interpret what type of jaundice is there, pre-hepatic or hepatic or post-hepatic obstructive. One is serum bilirubin, total and direct, write down. Serum bilirubin, total and direct. Urine, bilirubin you have done bile pigment, and in addition urobilinogen is done in a limited number of cases, not all cases. So, routinely whatever has been written in the red, in all liver function tests this is done, and you have to tell this thing before the examiner. So, one is serum bilirubin, total and direct. Second is urine bilirubin or urine bile pigment, urobilinogen. You write down ALT, that is alanine aminotransferase, or just write down SGPT. You note down from your book, this is available. Then AST/GOT, the same name. 3 enzymes are there, alkaline phosphatase. Gamma glutamyl transpeptidase is not included normally, but only it is done in alcohol abuse. I will tell you. Serum total protein albumin ratio, this is also a part of the LFT. So, serum bilirubin, serum in blood, serum bilirubin total and direct, ALT, AST, ALP, and then total protein albumin and globulin. But that's it. And we don't do any other type of test. Next, chalo jao. Glucuronidase transferase enzyme is done only on those cases we are supposed to have some defects like Gilbert's disease or Crigler-Najjar type of disease. These are rare diseases. Alpha fetoprotein is done, but not in only except in cancer. And there are other tests which you are seeing. These are historical significance. These are real functional tests. These we were told during our student life. But I have classified this thing and I have included this thing in my book which I wrote a chapter in 1991. So, these are the classifications I have made. There are some common investigations, there are some uncommon, there are some historical investigations. These uncommon or rare investigations are done in the higher centers like liver centers or gastroenterology department, not in the normally done in general hospital. Next part. So, these are the methods, as you say, these 5 tests, I am telling you, write down. Whosoever has not noted down, you write down this thing. But this is included in the liver function test in the blood. And urine bile pigment you have done, you have bile salt you have done, and in some cases indicated urobilinogen. But this is the actual liver function test for all practical purposes. And based on that you will be able to diagnose. This I have told you yesterday. You must remember this thing. পড়তে যাও, এটা দেখিয়েছি কালকে, চলে যাও, হ্যাঁ আগেটা যাও, হ্যাঁ এই দেখো, apart from sclera, when the disease is a little bit advanced, it also stains mucous membrane. Now, when you get this type of result, that undersurface of the tongue is also yellow colored, that means the jaundice is severe or it is of longer duration. Similarly, you see the surface of the tongue, you see the hand, see the nail bed. And in baby, particularly newborn baby, if there is a severe jaundice, even the entire skin, entire body becomes yellow. So these are very advanced cases. Next. So these are three types of jaundice you must be able to tell: hemolytic, hepatocellular, and obstructive. Hemolytic, why I say pre-hepatic, means before it reaches the liver. So extensive hemolysis is occurring, and that bilirubin is produced from the RE cells and it is being transported to the liver. So if there is an excessive hemolysis, that will cause an hemolytic anemia. Hepatocellular, if the liver itself is diseased due to any cause, if the liver is diseased, that is called hepatic or hepatocellular. And if after liver the bile is delivered into the common biliary common duct through cystic duct to the head of through that common bile duct to the duodenum, if there is any obstruction anywhere in the flow of bile, that is called obstructive jaundice. Remember, biochemistry LFT test is diagnostic and binding to everybody. So you cannot ignore an abnormal liver function test in any individual. You have any suspicion, get it repeated. But abnormal liver function test cannot be ignored, and you have to accept it as an abnormality. Whatever the patient says or whatever you see clinically, until and unless proved otherwise, that this is not due to something else. At the end, I will tell I got one case and I have reported it in the journal also. So as I told you, this picture I have shown. So hemolytic jaundice means before it reaches the liver. It is due to excessive hemolysis. And hepatic, this is called pre-hepatic because it is before liver. Hepatic means the liver is at fault. There is some problem, some diseases. So disease of the liver will call, and after that thing, in this part, it is post-hepatic or obstructive. And the obstruction can be here, it can be within the lumen of that CBD, it can be from outside. There might be a stone which will be blocking. So that will cause obstruction. If there is a cancer of the head of the pancreas, so that cancer will actually compress this structure. So bile will not be able to come here. So there will be an obstruction. Or there will be stricture. The lumen of the biliary duct or common bile duct has been narrowed due to some reason or other. So normal flow is not there. Do you understand? The normal caliber of the road is there, so traffic is flowing. Now, some part of the road is damaged, there is narrowing, so normal traffic flow will not be there, there will be blockade. So that you must understand, that happens. And I'll tell you in the disease, last time I told you that this structure, if you put a dye here, actually in reality, an endoscope is inserted and this endoscope is brought here, tip is brought here, then a dye is injected. Now the dye, if the pathway is plated, so it will flow like this. So you will get a clear picture of if it actually involves here, so cholangiopancreatography. You will get the entire structure here, you will get the entire structure of the liver also. So that is called endoscopic retrograde cholangiopancreatography, and that is done routinely. And if there is any block, you will be able to see where is the block, or what type of, if there is any tumor, that you will also be able to know. So why, yeah, now this is biochemistry part, pure biochemistry part I am coming. So hemolytic jaundice, it is characterized, write down, characterized isolated raised bilirubin level. No other parameters are usually involved in hemolytic jaundice. Isolated total bilirubin level. And in most cases it is predominantly unconjugated, because liver can take up 6 times as much normal load. So if that capacity is exhausted, then only hemolytic jaundice will appear. So it can be congenital, it can be acquired also because of the disease process, because of many drugs which causes hemolysis. One example you have known, that primaquine in G6PD deficiency. So even we take many drugs because of that drug, there might be hemolysis or there is mismatched blood transfusion. Extensive hemolysis will be there. And then that will cause a jaundice, temporary jaundice, that is a hemolytic jaundice. So it is basically because of the destruction of the RBC. So there will be diseases of the RBC. There are many diseases which actually limits the RBC survival. So that 120 days survival will not be there. So they will have a limited lifespan, they will have diseases. So that will also cause hemolytic jaundice. So if you suspect a case of, if you get an isolated bilirubin level elevation, think of two things. One is first, hemolytic jaundice, rule out. For hemolytic jaundice to rule out, you have to do a hemoglobin test, you have to do one hemoglobin electrophoresis or hemoglobin HPLC, so that abnormal hemoglobin is there or not, and third one is reticulocyte count. That you must do it. Hemoglobin is the first test. What is the level of hemoglobin? If the hemoglobin level is within normal limits, simply do a hemoglobin HPLC. So abnormal type of hemoglobin, that is called hemoglobinopathy, will be detected. Or there might be a defect in the glucuronidase transferase enzyme. These are the two possibilities. So jaundice in this case is usually mild. It is not that severe because liver is itself not diseased. As I told you, healthy liver can excrete bilirubin load 6 times greater than normal. So if that capacity is exceeded, then only it will happen. So neonatal or physiological hyperbilirubinemia, you have told, it is due to accelerated hemolysis of the RBC in a premature baby, or there will be immaturity of the glucuronidase transferase enzyme system. So in course of time, it really improves. And the main problem is that if the defect is so high or the hemolysis is so very high, and the bilirubin, if it exceeds more than 20 to 25 milligram per deciliter, normal value is about 1 milligram per deciliter, then it will go on staining brain, that is called cardiac arrest, and that will cause permanent damage to the brain. So that has to be prevented at any cost, because nobody wants, and nobody wants a defective baby with some, there will be definitely some neurological abnormality, and it will be lifelong. So immediately the patients are put on phototherapy. It is a phototherapy which you will be seeing in this. I think it is available in our, it is a low cost instrument, but what it does, it basically converts bilirubin into a more soluble form. Bilirubin, as I told you, is sparingly soluble, it cannot be excreted. So that using that phototherapy, one bilirubin isomer is formed, that is called lumibilirubin. That lumibilirubin is water soluble and that gets excreted. So they get cured of. So we have to use this phototherapy at 400 to 500 nanometer, that is peak is about 460. It depends on what type of, at what long you will take this thing. So urgent treatment is required because to prevent brain damage. Next. So non-hemolytic hyperbilirubinemia. So I told you because of the hemolysis it will occur. Non-hemolytic, these are the 5 different types you write down. So Gilbert case you will get it. OPD cases, if you are a little bit vigilant, you will find Gilbert cases. And I am telling you, one doctor I have found who is just aged about 55 years. At that age, I examined the sclera and found the sclera to be a little bit tinted. And bilirubin level was high. They advised all the hemoglobinopathy parameters. It was normal. What is said, you know, please don't tell it to my wife. Well, what happens? It is a non-pathological condition. You are having this since birth. It has been detected, you could not detect it. I examined it on a little eye. There is a very little, yellowish discoloration. Gilbert's disease, I am telling you, there will be a fluctuation of bilirubin level because of the stress. So it usually doesn't exceed more than 4 milligram per. Normally it is about 5.5 to 2 like that, less than 2. But due to stress, there will be a little bit more bilirubin, and that strains the sclera. And now it depends how long that stress was there. So sclera will be a little, it will not be normal. It will be a little bit evilish. So you have to have a doubt. So you will be able to diagnose this case. This usually forms a mild jaundice. Kriegler type 1. It is incompatible with life. There is absent glucuronidase transferase, and usually there is a death of the newborn. Kriegler type 2, there is a moderate. This is mild. Remember, this is mild deficiency of glucuronidase transferase. This is moderate deficiency in glucuronidase transferase. This is absent glucuronidase transferase. Kriegler type 1 may be an MCQ question to you. Predominantly, because conjugation is not occurring, glucuronidase transferase enzyme is defective. So predominantly because some conjugation will be there. Because it is, when it is absent, then it will not be at all. If there is a mild, there will be definite conjugation. So some unconjugated bilirubin, conjugated bilirubin will get it. Predominantly conjugated means conjugation has taken place. Now it is not been able to come out from the hepatocytes. So Dubin-Johnson syndrome, as I told you, through the biliary canaliculi, that conjugated bilirubin comes out into the bile. So if there is a decreased canalicular excretion, that is called, that causes Dubin-Johnson syndrome, and I have found one family in our own village. So there is black pigmentation also. And the third one is Rotor syndrome. There is a mild jaundice because there is a defect in the storage capacity of the conjugated bilirubin. So all these diseases are usually autosomal recessive in nature, and this Gilbert's disease which we see commonly, there are many types of Gilbert diseases. So mostly it is autosomal recessive, some are autosomal dominant. So hepatic jaundice, liver damage due to any cause, there are many causes. What I want to emphasize that viral hepatitis A is a waterborne disease, means water, if it is contaminated with the fecal matter by any chance which contains viral hepatitis A, or that water, I mean through the food chain basically hepatitis A infection occurs, and usually recovery is there, 100% recovery is there. As a medical student, medical person, you must be worried. Vitamin A, viral hepatitis A and E, these are all waterborne diseases and these are curable. But B and C, you might get from the patient. These are transmitted through body secretions, through blood. So while you will be handling the blood, think every patient is suffering from hepatitis B or C or AIDS, HIV, and handle accordingly. And it's a peculiar nature of the sufferers of the chronic diseases, be it tuberculosis, be it hepatitis B, they try to transmit the disease in the society. Normally a patient doesn't cough, or even if he coughs, there is a cough etiquette. He also covers this thing with a handkerchief. But those who are suffering from open tuberculosis, they usually cough so that they want to transmit the disease. And hepatitis B is another example, and most of the patients usually get the infection from the saloon. So I advise, once I have known this thing, I have purchased a separate set for that and ask that barber to wash your hands thoroughly with the soap before you use this thing. Because through that instrument, hepatitis B gets transmitted. Through the needle prick, accidental needle prick through the blood, contaminated, there might be wear and tear on the surface of the hand, through that virus will enter. So be careful about this thing, hepatitis B and C. So these will usually lead to chronic diseases. Most of the time it can be cured also, but it will lead to hepatitis B, and hepatitis B, it's a progressive health deterioration, and patient may also develop liver cancer. So many persons are taking alcohol, they are having an alcoholic hepatitis, and drugs also. Common infection, you have to remember hepatic jaundice, remember at least this you try to tell, hepatitis A, B, C and E, these are the common types, and any disease of the liver. Obstructive means, as I told you, there will be some obstruction somewhere in the biliary tract and carcinoma of the head of the pancreas, or first common is the stone in the bile duct. That causes, you must remember, if you get an obstructive jaundice, think first this one, and then you think of carcinoma head of the pancreas if the person is aged. Or if there is a stricture anywhere or in the block from outside, inside, pre-hepatic, if there is any lymph node enlargement. If you understand, the moment you read this liver, when the liver pre-hepatic, you will see through pre-hepatic common hepatic ducts are coming from both sides, and there will be compression. So there will be intrahepatic cholestasis, and that will cause obstructive jaundice. See, this is my closest friend from village. He was operated on 27th of July. The largest stone I have seen this. Can you see the stone? He did not have any symptom, and the LFT was also, it was within the gallbladder. So there is no abnormality in the liver function test. He used to have constipation. For that, an USG was done, and accidentally such a large stone, single stone, was recovered, and this happened, what I personally feel, is more than nearly 15 to 20 years time. Gradually this, can you see the size? 1 inch diameter, 2 inch length. It's a huge. So GB stone per se doesn't cause an abnormal LFT. It can be detected only by ultrasound. Why I am saying? Because this is a real time. The stone is still there in the, I have given it to them. So what are the normal functions of the liver? This you note down in examination for purposes. So this is the largest biochemical factory of the laboratory, main organ of metabolism. Write down 5 functions and you read it from the book. One is metabolic. You know all the metabolism are done by the liver. And then synthetic. Remember, this point I am trying to emphasize. Exclusively albumin is synthesized by the liver. And the globulins except gamma globulin. Gamma globulin is synthesized by the plasma cells and the clotting factors. Detoxification, excretion, and storage. Storage function, vitamin A, D, K, and B12. B12 is stored in the vitamin, although water soluble vitamin, but liver stores vitamin B12. The synthetic function, as I told you, all you know, albumin I have told you, globulins, alpha, beta globulin, gamma globulin is synthesized by the plasma cells. Carrier transport proteins are also synthesized by the liver. Bilirubin you know, bile acid you have already been told, cholesterol, triglyceride, lipoprotein, phospholipids, all these things you know. So there is a synthetic function. Next. So albumin synthesis, remember, only organ in the, that is the liver. And normal level is 3.5 to 4.5. Note down this thing, this is important clinically. So albumin is responsible to maintain the osmotic pressure of the plasma, and it maintains the extravascular and intravascular fluid volume. If the albumin level is decreased, then there will be edema, and you will see the picture. So if the liver is diseased and extensively diseased, then albumin, and that's a chronic, not acute, then liver will not be able to produce adequate amount of albumin, and in this case that hypoalbuminemia will occur. So 2 common causes of hypoalbuminemia, write down. One is hyposynthesis by the liver, or excretion, over excretion by the kidney. So usually you have done protein estimation in urine. So usually in nephrotic syndrome, hypoalbuminemia is there, and another cause will be asked. Don't forget to say that is chronic liver disease, long-standing chronic liver disease, not an acute liver disease will not cause, because acute liver disease will recover. So in course of time we will get. So chronic liver disease will cause hypoalbuminemia. So less amount of albumin will be in the blood, so there will be less oncotic pressure. So if you there less oncotic pressure, you will clinically see there is a pedal edema, there is ascites, and from the facial appearance you will be able to, once you note down this, see this thing, that will be basically a liver function, that hypoalbuminemia is there, absolutely. In both the cases, this case is due to liver disease, this case is due to over excretion, by the kidney, that is nephrotic syndrome. So synthesis of clotting factors, one note down here, 1, 2, 5, 7, 9, 10, 11, 12, these are actually produced by the liver, and vitamin K dependent factor, this is an MCQ question, 2, 7, 9, 10. So that from examination purposes it is important. So common markers of liver function test. Common markers, you write down this slide also. Markers of liver enzyme, serum, SGPT or ALT, it's a marker for liver injury. And using this thing you will be able to diagnose LFT. Serum alkaline phosphatase, marker of cholestasis, means obstruction. Serum GOT, it's a marker of liver injury. It is usually alcoholic cases you will get it, or in chronic liver disease. Gamma glutamyl transpeptidase is usually done to determine alcohol abuse, because most of the alcoholics don't admit that they have stopped taking alcohol. They will say, I have stopped it. But you measure gamma glutamyl transpeptidase, if the level has not decreased, that means the patient has not, that person has not stopped taking alcohol. The simplest way. If there are things, this jaundice, this sclera will be yellow, as you know, and there will be mismatch. You will be doing the test, patient will complain symptoms, or there will be symptoms, and you will get a mismatch between among all the three. Patient symptom, you will not match with the LFT report will not match with the sclera color. So you just note down the enzyme levels usually appears fast, it is the last to decrease. It is the last before actually bilirubin. So in the pre-ectatic phase, means even before the jaundice appears, the patient might feel uncomfortable, and at this stage if you do, the liver enzymes will be increased, symptoms will appear next. A serum bilirubin will be increasing thereafter. Urine bilirubin will appear after serum bilirubin has been raised, because that bilirubin has to be excreted. Ectatic sclera will not stain immediately. Some amount of time will be required. So that is the sequence. Similarly, disappearance from the blood, from the serum, from the color, it all depends. One example I have given, maybe an useful, say on a lighter mode, that in 2012, TMC came into the power, and the CPM party leader, affiliated leaders shouted in director's office like anything. Then I told at the end, sir, it is a case of jaundice. Why? Now there is no bilirubin in the blood, but sclera is still tinted. They have lost the election, but still they think that they are in power. So even when it is a chronic jaundice, the sclera will remain stained, bilirubin will disappear from the blood, bilirubin will normalize, but sclera color will not come down, because it will take a longer time. So there will be mismatch, patient will be confused, doctor will be confused, and the caregivers will also be confused that the liver report is abnormal. Still they are having, the ELS discoloration. So this is longer term. Next part. This part I have told you. Why unconjugated bilirubin cannot come out? Because it is bound to human serum albumin. Now you see the conjugated bilirubin, basically bilirubin molecular weight is this one. Now 2-diglycuride will give 937. In contrast, unconjugated bilirubin gets attached to albumin. Albumin molecular weight is 66 to 67,000. So this is a large molecular weight protein. Large protein that will not be filtered by the kidney. That is the reason why unconjugated bilirubin doesn't appear in the urine. What is that? As I told you earlier, isolated elevation of bilirubin is the hallmark of hemolytic jaundice. So unconjugated bilirubin will be more, conjugated bilirubin will be less. Rest of the liver function test will be normal. What is that? If you do urine will be normal, also appearing normal, but on standing it will be aquauric, because there will be no chloruria. Similarly, urobilinogen, if you measure in this case, it will be high, because huge amount of bile pigment will come into the intestine, and that will cause a high bilirubin level. A stool will be dark brown color because high amount of starcobilinogen will be there. Liver was not depicted. Liver is excreting huge amount of bilirubin. পরেরটা দেখো hepatocellular bilirubin conjugated part will be more because liver has synthesized conjugated bilirubin, unconjugated part will be less, and total protein, albumin, globulin, all these things will be normal in otherwise acute cases. In chronic cases there will be decrease. SGPT will be very high because preformed enzymes will be released in huge amounts in the blood, and the normal level of SGPT is 40. I have seen 12,500 in a jaundice patient. That large amount of SGPT will be released. Similarly, SGOT, it is not in that proportion because quantitatively SGPT is in much more concentration than SGOT. That's why in a case of viral hepatitis, the SGPT level is disproportionately higher than SGOT level. In contrast, in chronic liver diseases like alcoholic hepatitis, SGOT level is increased because of the mitochondrial damage. Next, part দেখো. So urine, if you examine, there will be high colored bilirubin. Bilirubin is present, and if you do bilirubin, it will be present. Bile salt, it will be also present. So urobilinogen will be normal, or it can be less because if there is a slight block, then there will be less. Stool, it will be normal color, or there will be slightly white is because of the degree of obstruction. Because hepatocytes will also undergo swelling, and that will decrease the biliary canaliculi. So the normal amount will not be, bile will be there. So that is the reason why you will get this thing. পরটা দেখো, obstructive jaundice. Remember, predominant conjugated hyperbilirubinemia, and the hallmark here is alkaline phosphatase. Alkaline phosphatase is present at the sinusoidal membrane and the biliary canaliculi, and they get stimulated, and the huge amount of alkaline phosphatase will be present, but the SGPT and SGOT level will be normal. So by looking at the level of the enzymes, you will be able to diagnose whether it is viral hepatitis, whether it is a case of obstructive jaundice. So ALP level isolated just like bilirubin, hemolytic jaundice, where unconjugated hyperbilirubinemia will be there. Here only isolated elevation of alkaline phosphatase, and there will be conjugated hyperbilirubinemia. পরেরটা দেখো, if you do the bile salt, urobilinogen will be absent totally, and because of that thing, since bile is not able to come out into the stool, so stool will be clay colored. If it is obstruction is complete, if there is a obstruction is incomplete, the normal yellowish discoloration of the stool will not be found. So it will be slightly whitish. পরেরটা দেখো. So this is a summary of what I have told you. So SGPT level will be very high in the initial stage. As the disease progresses, there will be this fall will, come down very rapidly. Suppose in today somebody has come with a viral hepatitis. I have seen in what doctor's son, the bilirubin level was 3.5 and SGPT level was 7,500. After 3 days he becomes suspicious and did this test. The bilirubin level was 5 and the SGPT level dropped to 500. Then he told that your calibration of the machine is there or not tic-tac, because now the bilirubin has increased, SGPT has decreased, and that is the actual picture. Because stored hepatocyte enzymes were there that got released, bilirubin level was started increasing. So now the liver cells are damaged, they cannot synthesize that much amount of SGPT, and that is the reason why SGPT has dropped to that extent. And I told him that don't worry, your son will get early recovery because there is no more further damage to the liver. That is indicative of by seeing and looking at the liver level of SGPT. SGPT has come down. If the SGPT level would have increased also, that means there is ongoing liver damage. But since bilirubin is increased, because now bilirubin liver cells are actually diseased, they are unable to conjugate this bilirubin, but there is no further damage to the liver, it has started healing. Next. So again, just by looking at the level, anybody wants to tell anything else? Pre-hepatic is hemolytic. বলো বলতে থাকো ভুল বলি ঠিক এখন ঠিক করে দিচ্ছি। এইটা দেখেই বলে দিতে পারবে। বলো একজন কেউ বলো। আর কেউ? অবস্ট্রাকটিভ কি জন্য? জোরে বলো। রাইট, কারেক্ট আনসার, অবস্ট্রাকটিভ। বলো বলো, ওটা বলো। SGPT লেভেল বেড়েছে। SGPT লেভেল কোথায় বেড়েছে? এখানে নর্মাল। SGPT লেভেল নর্মাল আছে, 35 আছে। ALP level is the hallmark of obstruction. You see the level of ALP here. You see the level of conjugated bilirubin. You see the total bilirubin. Just look at the enzyme. The moment you get a bilirubin level high, look at the enzyme level. Isolated elevation of alkaline phosphatase. So this is a pure case of obstruction, obstructive jaundice. পড়তে দেখো। This is pure case of obstructive jaundice. রেজিনা পড়তে। স্যারেলে বলো তো একটু দাঁড়াতে। স্যারেলে বলো একটু দাঁড়াতে। এটা বলো, ঠিক করে বলো। কে বলছো? জোরে বলো। আরে বলো না, আমি ভুল বললে আমি ঠিক করে দিচ্ছি এক্ষুনি। মি করে বললে বোঝা যাচ্ছে না। একজনকে ভলান্টিয়ার করো, বাকিটা ভুলটা আমি ধরে দিচ্ছি আমি। দিস ইজ ইউ হ্যাভ টু ইন্টারপ্রেট। হ্যাঁ, হেপাটিক জন্ডিস। হেপাটিক জন্ডিস কি জন্য? হেপাটিক জন্ডিস বলো, তুমি বলো। দাদা চলো, ওঠো। কোনটা বলো? মার্কার? হ্যাঁ, অবস্ট্রাকটিভ না, একদম পুরোপুরি অবস্ট্রাকটিভ না, বিকজ এলপি নর্মাল আছে। SGPT is the hallmark. If you look at the bilirubin level, it is high. Conjugated bilirubin is high. Look at the level of ALT. It's pure case of hepatocellular jaundice. Okay? এই রেজিনা তুমি চলে গেলে হবে কি করে? এইটা বলো, বলতে হবে। এই তোকে বল, এবার বলা করবো সবাইকে, আমি ভেতরে যাবো। বল কি আছে? হ্যাঁ, আমাকে ফেল করেই ছাড়বি? বল শিগগিরি। হ্যাঁ, হেপাটিক জন্ডিস, কারেক্ট। হেপাটিক জন্ডিস বলো তুমি। বড় দেখা না, এটা হেপাটিক জন্ডিস বলছো। একদম পাক্কা। এটা রিকভারি ফেজে আছে, একটা ক্রনিক লিভার ডিজিজ টাইপের আছে। দেখো SGPT লেভেলটা দেখো অনেক বেশি আছে, প্রিডমিনেন্টলি আছে। কিন্তু নর্মালি যত আইডিয়ালিস্টিক কেস তুমি পাবে না সব কেসে, বিকজ ইউ ডোন্ট নো দ্য হোয়াট ইজ দ্য ডিগ্রি অফ ড্যামেজ অফ দ্য হেপাটোসাইটস। So at times if the mitochondria is also involved, then that SGPT level will also be high. And it might be a case of acute alcoholic hepatitis also. He has taken a consumed alcohol for a quite longer time, and that's why you see the bilirubin level, it is not that high. But you see there, in contrast to that one, that is 7,500. That was the actual report from our hospital doctor's son. And this is another report which I have also found. And you see this one. Now this is a case of, again, it's a case of hepatocellular jaundice. Is this part clear? Look at the level of bilirubin first, whether it is normal or high. Then look at the level of the conjugated or unconjugated bilirubin. And then simply look at 3 enzyme levels. And if you cannot conclude, then only look at the total protein albumin level. If the total protein albumin level is normal, it is not a case of chronic. If it is reversed, that means albumin low, globulin high. That means it is a chronic liver disease. Normally the albumin ratio is 1.5 to 1. Now if that is reversed, means this albumin level is low but globulin level is high, then it's a chronic liver disease. Was the agree? A part of that? Yes. Last 8 take a ball. 8. Yes, chalo. 8 bolo. Yes. Yes. Eta bolo. Eta bolo. বলো 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 যোগ্য বলো। হেমোলাইটিস জন্ডিস কে কে বলছো? হাত তোলো। বাকিগুলো বাকিগুলো কি হলো? বাকিগুলো কি হলো? এগুলো ঠিক ঠিক বলেছে। বলো কে বললে? হাত তোলো। এই দিক থেকে পেছন থেকে বলতো। কে হাত তুলেছিলে এখানে? কে হাত তুলে? কে হাত তুলেছিলে? তোমাদের মধ্যে হাত তুলেছিল কেউ? কেউ হাত তুলেছিলে? বলো 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 বলো। এটা কেন হেমোলাইটিস জন্ডিস? বলো বলো বলো। এটা না বলে ছাড়বো না গো। Look at the level of bilirubin. It is high. Unconjugated bilirubin is predominantly high. All the liver function tests are normal. বলো তুমি এতক্ষণ ধরে চুপ করে বলে তো দিলাম সবকিছু, আনসার হয়ে গেল এতক্ষণ ধরে। তাকে দেখতে হবে, তুই দূর থেকে ধরলে দেখতে পাবো কি করে ফিগারগুলো। বোঝা গেল? তাহলে LFT দেখে বোঝা যাবে, বেশি কিছু করার দরকার নেই। এইখানে যদি না দেখতে পাও, then you go for further investigation. In most of the cases, you will be able to diagnose by looking at the level of, as I told you in the beginning, serum, bilirubin, conjugated and unconjugated, 3 enzymes. All these 3 jaundice can be diagnosed. Okay, thank you. I got only in my lifetime only 1 case. This I reported in journal. See what happens in this case. If you look at the serum color, it is just like 0.3 to 0.5. But I got a bilirubin level of 7.6. It cannot be. There are 5 such cases reported in the world literature. I analyzed into the depth in this sample. No paper could describe what is the solution to this problem, and my paper was unique in the sense that I gave a solution to the problem. But what are the situations where you will get a high bilirubin despite having a normal serum color? There is a positive interference, and in this case it is due to multiple myeloma paraproteinuria. So that caused, say, this is an underlying cancer that can be detected again by doing an LFT. One must be vigilant that in a laboratory practice or in a clinical setting, that when this type of serum is there and abnormal hemoglobin is, bilirubin is there, that means there is some positive interference in the assay. That was reported also.